Okay, so I'm Aiden Rainey. We also have Joe Walsh with Murmur and D. We're happy to have Philippe Genereaux on the show today. Philippe is the director of structural heart at the Gagnon Cardiovascular Institute, and he's going to discuss stages of cardiac damage related to valvular disease and how this led on his path to designing clinical trials, important trials, including early TAVR and progress.
Sweet.
So take it away, Philippe.
Let's do it, bro. Your hair is looking amazing today, Philippe.
Oh, thank you. I need to a little haircut for TCT because big moment at TCT. I need to be chicken swell, But
early TAVR, man. Early TAVR, baby. Just tell me whether to short the Edwards stock or to buy some more.
Well, I can't tell anything, and I'm terrible. First of all, you should never listen to a doctor for stock because my understanding of Wall Street is like a 15-year-old girl. It's very, very emotional. Even if they should be rational, they overreact to everything. And sometime in the wrong direction. I'm like, guys, what? Like, I thought it was supposed to be good for the field. Or what? This is supposed to be bad. And so I never take any advice from doctor, especially when they know, because they think they know and Wall Street knows something else. And I don't know. I think we should listen to advisor. First of all, thanks for having me, guys. It's I've been following your channel, and what you do is remarkable and very fun and very instructive, and I think is very disruptive too. So I'm sure you're gonna have a long life with this channel, and thanks for having me. I'm happy to share my journey and the last I would say 17 years in US already. So I think you asked me to talk a little bit about the staging of cardiac damage, but the reality is this concept emerged really in preparation of the trial, of early TAVR trial, when I was in 2015 at CRF. I was still at Columbia University and a little bit at CRF and trying to understand how to design trial. And I was publishing a little bit of paper, and I want to inform early TAVR. I want to say, hey, from the partner trial, from all the TAVR study, is there a group of patients that we intervene that look better, like no symptoms, maybe no damage, like really LV normal and EF normal and not too thick. And I decided to say, hey, why don't we look at patient and partner and that had surgery and TAVR that had no damage, and then we look at their outcome. So, and then I said, I observed like in AS patient that, when you look at all the literature, RV dysfunction is the worst. People that do RV is bad, and people with PH is bad, pulmonary hypertension is bad, and people with big LA and mitral, MR, and AFib is bad. You have like 25 paper a week that show that AFib is bad for everything. And then you have, diastolic dysfunction is bad, the LV hypertrophy is bad, strain is bad, and then you have LV, which is bad. So the goal was really to try to divide people in, okay, if you have AS and you wait, the LV get thick and get enlarged and accommodate, but then will go down, and then maybe the LA will enlarge and MR will come, and if you wait 1 or 2 years, pH will go up. This is what we learn in medicine, left to right heart failure propagation, and the lung will sweat a little bit, and you're going to have fluid accumulation, pH will go up, and then whoops, RV will not like it, TR will start, and RV will enlarge. So the left to right propagation of heart failure and a hypertensive heart or aortic stenosis heart, for me, was totally the base of this. And I think that was just describing what everybody knows, and say, let's put that in a nice graph and say that stage 0 is no damage, stage 1 is a little bit of LV damage, and stage 2 is LA damage and large AFib, MR. Stage 3, the lungs start to take the hit. Stage then the tricuspid start to leak, and stage 4, the RV is down. And turned out that it was beautiful curve of predicting mortality after a successful AVR and TAVR. And I thought it was great. I said, I think I can have a frailty score of the heart, how frail is your heart or not frail. And at the time, frailty was big, and people were trying to say STS is not good. And then I turned out that this is better than the STS, is better than frailty, is better than anything. This was the strongest predictor of mortality after TAVR or SAVR. and makes sense. You have 25% increase in mortality by stage. So I thought that was a great curve, and I started to write the paper, and almost got in New England. Actually, almost got in New England.
Oh, your life.
I was like, wow, but people didn't like it. It was retrospective, and then got rejected by Jack in 2 days. Got rejected by circulation in 2 days.
No way.
Yeah, I think it was like because the guideline already have a stage A, B, C, D that I'm not sure people know about or use, but they don't like the semantic of stage. So maybe I should have called it level of cardiac damage. And then Open Heart Journal, after multiple rounds of revision, finally accepted it. And turned out this is the third paper, the most cited in the Open Heart Journal for the same time frame of since 2015 or 2017. So, but it took a lot of persistence to publish this. But and now there's like 60 papers validating this. This is kind of people have accept the concept of cardiac damage, even if people don't always agree with the semantic of damage. I think, it's like diabetes. When you have end organ damage, everybody think it's okay. So I think for me, is cardiac damage was great. But I always thought I was describing a phenomenon that was very basic, which is what we learned in Medicine 101, left to right propagation of heart failure, that worked for hypertension, that worked for everything, left to right. So, and I use this to predict early TAVR. I use a stage 0 to say, hey, there's patient, if you start TAVR in stage 0, this is going to be the mortality. Compared to if we wait, if we have a mix of stage 2 and 3, if we wait 1 or 2 or 3 years, that's what's going to look like. So I use the data from PARTNER to design early TAVR, and turned out to be a very important paper. And then early TAVR now is done.
By the way, Philippe, did you want to show some of those slides for people to see who haven't?
Yeah, I mean, I think if you, I can show quickly a little bit. And I always like to start with this and saying that one of the other dogma I'm literally attacking right now is the valve area severity of less than 1, which is, for me, it's not appropriate for women. It's not appropriate for tall men. I think, the dogma we have, AV less than 1 and peak velocity more than 4, it's so arbitrary, it's so random. And that's why I developed the staging, say, hey, why don't we, when you have 1.1 or 1.2 or 0.9, why don't you look at the cardiac consequences? So we know we have a grading, which is not perfect, with the Bernoulli equation and the continuity equation. It's not even a measure of distance. It's a measure of work of the LV, by the way. Why don't we help ourselves with the cardiac consequences? And if you go to the next slide, I designed this, this slide really, again, to tell to people, when we see a lot of people, I think 25 patients with severe AS every week in clinic. And I can tell you, some people don't like moderate AS. Some people have 1.1, 1.2, mean gradient of 26, and they're short of breath. On the other hand, you have the bicuspid guy, 62 years old, peak velocity of 5.5, running marathons, and I'm fine. So I think there's a variability in patient tolerance to adverse event, and they express their disease differently. And that's why the dogma of 1 and 4, I think the guidelines are there to guide, but some people take it as the absolute truth, and that's a problem. And that's why we need early TAVR and progress trial to show, hey, the guideline are a guideline, but there's a high proportion of patients with moderate AS that don't like it and have bad prognosis. So I think it took TAVR, a less invasive option than surgery, to allow us to dream about this, helping patient earlier and prevent and be preemptive and preventive. Because before AS was a dormant disease and was, okay, AS, use surgery. And then people want to push that back because opening the chest is not fun. Now that we have a solution which is less invasive, now we can investigate, can we be preventive? If we get in, get out in 20 minutes, you go home the next day, the valve lasts for 15 years. Well, guess what? Maybe we can go moderate. And yes, you're going to need 2 valves, but you're not going to have cardiac damage. And the cardiac damage that you avoid will save your life, maybe give you 2-3 more years of life. So that was the concept.
This is so important, Philippe. I mean, I think your contribution in this field has single-handedly moved clinicians away from the paradigm of the Ross and Brunwald curve. Because I really think every doctor has this indelible memory of the Ross and Brunwald curve, which, all due respect to those pioneers, was based on 60 patients. And there's just this binary thing where if you see severe and the patient has symptoms, all roads lead to TAVR. But it's not that simple, right? It's so much more complicated. And I think you've been able to tease out a really elegant paradigm shift in the management of AS.
Yeah, I agree. And I think we all see these patients, and it's hard because you've got the guidelines on the one hand, but as a TAVR operator, you just know these patients are going to do better. But, you know, we have confidence, and like we need to have data to support this stuff. So, I mean, I think it's amazing the trials that you've designed.
Well, thanks, guys. And I think one of the problem is the echocardiogram. Echo is a screening tool, okay? And when you look at the variability in measurement, I'm like, it's hard. I mean, it's hard. I mean, here at Morristown, we have tech that take an hour and a half to trace AS, and they find severe AS on the vast majority of people. But if you go in the community, sometime they don't have time to do this. They do 40 echo a day. It's 10 minutes, and they screen and say it's moderate. And now they banalize moderate. Oh, it's okay. It's only moderate. I see you in 2 years. But then the reality, they underappreciate the severity, and it's severe. So for me, the key message is echo ultrasound is a screening tool. If you have moderate, send the patient to the valve center.
Absolutely.
We're gonna take care of, do a maybe in-depth echo. We're gonna do a CAT scan with calcium score, and then we're gonna do an NT-proBNP, and then you're gonna put the patient in the right box for management. It's not only treatment, it's management. Okay, you're a true moderate AS. The guidelines say 1 to 2 years follow-up. And I want to see you in 6 months, because you know what? I want to see your trajectory. Maybe you're moderate and next time you're going to be severe. So I think this is what I do. I bring back the patient, redo the testing, and then I see them in 3-6 months to see their trajectory. And guess what? 80% of the time, the moderate AS, when I follow them, they're severe the next visit.
Wow.
So I think that the key is refer your patient in a valve center, an excellence, valve excellence, valve center of excellence, where it's comprehensive imaging, and you're going to steer the patient in the right direction from the get-go, not 2 years later in the ER with EF at 20%.
100%.
Absolutely.
So this is a 3 paper that we published, and you can go to the next slide. And the concept of cardiac damage was really to assess the extent of extravalvular cardiac damage, to not only focus on the valve, but is there a relationship with prognosis when we look at the LV, the LLA, the lungs, and the RV. So that was just this, and very similar to cancer. We want to see, yes, the grading of the tumor is important, but we know the prognosis is depending on the staging. Everybody know what is staging, stage 4 cancer mean. So that's what we wanted to do. So here's the next slide.
I actually include your slides in all my outreach talks, and I'll show the slide that I always put in. But the first thing I show is the staging of cancer, right? And so you want to catch cancer when it's carcinoma in situ, not when it's metastatic. And so your staging classification draws parallels to that cancer paradigm. And I think it's very legitimate. It's like just using LDL to screen for coronary disease. Like you need Lp(a), you need calcium scores, you need other stuff. So it's much more elegant.
Yeah. So we published that in 2017. So already 7 years, looked like yesterday. And what we did is very simple. We took like around 1,500 patients from the partner trial. All those patients were severe AS with symptoms or so, and they had TAVR or surgery. And we divide them in 5 groups. And the first group was just severe AS, nothing else, normal heart, normal LV, everything is normal. Then stage 1, the LV start to be thick, either LV mass increase or diastolic dysfunction or EF less than 50. Then stage 2, the pressure increase. If you wait a little bit longer, the LA start to get the pressure and it dilate, or you have moderate to severe MR, or you have AFib. And stage 3, the lungs start to get the hit if you wait, and the PA pressure is high, or the moderate to severe TR is there. And if you wait long enough, I mean, LV disease will transmit to the RV, and you have RV failure. And if you go to the next slide, what was shocking to me in partner trial, only 6% of the patient had no damage. Okay, so
Wow, that's crazy.
Yeah, and 15% stage 1, 50% stage 2, 20% stage 3, and stage 4, 7%. So already more than 94% of the patient had very advanced, what I call metastatic AS. So not only localized in situ, like you said, Joe, but extending already to the LV, the LA, the lungs, or the RV. And when you look, 25, almost 30% stage 3 and 4, it's ridiculous.
Yeah.
What are you waiting for? And then obviously people say, oh, it's not it's because of coronary disease, it's because of the lungs. For me, it doesn't really matter, because you're going to see some analysis we did, but it's just to show how vulnerable those patients are. So it's, this staging works with pure AS, but it's also work in real life when people have multiple comorbidity and competitive disease. And that's are very vulnerable to AS, because guess what? They have COPD also and coronary disease. So,
Hey, Philippe, do you notice in these stage 0 patients, what would you say is the prevalence of overt symptoms when you see them in clinic? I mean, you saw a lot of early TAVR patients. Like, are these patients generally asymptomatic, or, I mean, does it kind of depend on how much activity they're doing? Because I think this is another important point, is that we don't do a very good job of asking about symptoms, right? I mean, the surgeons do this better than we do. They say, is there anything you were doing 10 years ago you're not able to do today? And they talk to their spouse. We asked the whole litany of syncope, angina, dyspnea. Like, what have you found in these stage 0 patients in terms of symptomatology?
So it's such an important question, Joe, and I'm glad to say that early TAVR, the trial of CVRS no symptom comparing TAVR versus clinical surveillance, is done. 901 patient is going to be present in, I think, 3 months at TCT. And I can tell you that, to our surprise, among patients with no symptoms, normal stress test, cardiac damage is frequent. I'm not going to say more, but cardiac damage is frequent among patients with severe AS, period.
Got it.
And asymptomatic. And you're going to see, a lot of analysis would come from early TAVR about what is the damage at the beginning, what is the progression of damage, what is the impact of damage, is stage 0, what is the stage 0 and patient with really nothing. And I think one thing we know is the progress trial, which is moderate AS, is done. We did this trial in literally 18 months. And I think we see, I mean, is there a benefit to go beyond severe? Is severe too late? Yeah, probably, because if you already have severe AS with no symptom and you have 50% of the patient with cardiac damage, stage 2, 3, 4, or stage 1, 2, 3, well, you kind of miss the boat. It's depending what you want to prevent. You want to prevent death? Maybe. You want to prevent cardiac damage? Probably. So I think that's, I see the staging as also as an endpoint. So when I designed the staging, it was just to classify patient, stratify patient, but now I see it as an endpoint. I don't want stage 1, 2, 3, or stage 2, 3, 4. The proportion of patients that evolve to stage 2, 3, 4 should be 0. So that's what's the concept behind. So if you want to go to the next slide, I just want to show you the money slide. Yes. So, when people said, for me, when I look at the slides, like probably the best, there's no better stratification in life than that. Like, it's almost like 5% on every line. And, this is after successful AVR, successful TAVR or surgery. There's like half. I mean, you're successful, you go home, you're happy, and this is your curve. So, well, I don't know where you want to be, Joe, when you have your TAVR, but I like the blue curve. I would love to have 4% mortality at 1 year, not 25. So, and the 25% mortality in stage 4 is staggering. It's like cancer stage 4. So, and if you go next slide, this is also true for cardiac death. Cardiac death this is the same. It's not only all-cause death. And if you go to the next slide, this is part of my favorite slide, and the reviewer number 2 is always a pain, and say, everyone is like, oh yeah, Philippe, it's because of coronary disease and COPD or damage. It's not because of AS. I say, guys, I'm going to remove all the patient with coronary disease and COPD and partner. And if you go to the next slide, this is really good. And I say, thank you so much for your comments, and the relationship is even better. And if you go to the next slide,
it's very similar.
It's like there's a group that has 0% mortality, cardiovascular.
Wow.
So for me, I'm like, okay, life happen. You know, you're gonna have patient on oxygen tank in your office that coincidentally have AS. Well, it's better to have one disease than two. So if I fix AS, you're gonna live longer, and you're probably gonna have 50% improvement in your symptoms. But for me, there's a group, if you don't have lung disease or coronary disease, that may have a very good result. And this is why we design early TAVR to say, you know what, guy, I think if we start early, before there's nothing, let's say you have AS, moderate, severe, I don't know where's the sweet spot. It's probably not severe. Severe is too late, in my opinion. But let's say you go moderate and you have no damage. That would be great to be able to intervene and never develop the damage. The reality is we need a valve that will last a long time. That said, if the progression of the disease, you're moderate and you go to severe with symptom in 3 years, guess what? If the valve lasts for 15, that's great. That's okay. You will need a second valve anyway.
Yeah.
Second thing, we did a lot of moderate AS patient with TAVR. It's fun. There's no calcium. The valve expand, and maybe it's more circular. It's going to last longer. It's like putting a stent in a super calcified 90% lesion where you need roto compared to a type A lesion. Slam dunk this thing. Of course, the ISR and the stent thrombosis would be higher in a rotolablator lesion, 99% calcified, versus a type A lesion. So I think right now I'm starting to think about TAVR valve the same as a stent, as a coronary disease. I want to put a TAVR when there's not a lot of calcium, there's a disease, but when I can put a valve, it's going to be fully expanded and not squished because there's like peak velocity of 5.5 bicuspid, 0.4 valve area. This is way too late. I will need valve modification. I will need to split this leaflet to remove this. I need a rotoblator of the valve, which is probably shortcut or whatever. And now maybe we're going to improve those outcomes. Why don't you do it when it's moderate, when there's no calcium? So I think that's the rationale and where my brain is at this point.
So Philippe, I think this slide's so powerful, and I think every referring physician needs to see this, because what they need to understand is by referring your patients late and holding on to them and doing that 1 year, 2 year echo, they're doing their patients a disservice, right? Their long-term outcomes are going to be worse. And so I think that's a really powerful message that we can do as structural operators to educate our referring physicians, is that you need to get them in early, just like you said, at the moderate stage, so we can at least follow them more aggressively. Question for you though, is there a signal for procedure related outcomes based on staging? Because this is at 1 year, but I mean, because my feeling is that a lot of these patients can get through the procedure of the TAVR relatively safely, but did you look at this in terms of inpatient mortality or inpatient outcomes?
Yeah, if you look at the curve at 30 days, right there, I mean, there's a stratification. The one that, so, and you know, what I like about the staging is, let's say you have a frail patient. There's a strong interaction. So a frail patient in stage 0 would probably survive, but a frail patient in stage 3, 4, that's the problem. So I think it helped. The staging can help also to predict, to talk to the family. Now, when I see a patient in the office, we all have this, let's say 92 years old patient, and then is in a wheelchair. Okay. I look at the echo and I look, okay, LV normal, not hyperdynamic, no MR, no TR, RV okay. I probably can get out in conscious sedation and he's going to be fine. If I look at the patient 92, pH is like 60, he has EF is 30, he has moderate to severe TR. I'm walking on eggs here, you know, and I'm not sure. I think it's futile. I think I can help. I will certainly improve in mortality, but the mortality will be on those patients at 30 days, 1 year would be almost 30%, 50%.
Yeah.
So I think this thing help also to have communication and share decision process with the family. And definitely this thing predict mortality at 30 days, 1 year, and 2 years.
Yeah.
That's brilliant.
Yeah, you're rearranging deck chairs on the Titanic for some of these stage 4 patients. You know, you are improving their mortality. That's so high.
So Philippe, quick recap. We have early TAVR, right? Asymptomatic severe AS. Progress, which is moderate AS, even kind of a step further. Early will be out at TCT, which will be this year. And what about progress? When will that be out?
So Progress, we finished in December last year. So this is a 2 years endpoint. So Progress is moderate AS patient, 1 to 1.5, 20 to 40 mean gradient with symptom, or they could be asymptomatic in Progress, or with sign of cardiac damage. One sign of those, what I show, LV, LA, PH. And it's going to be the data will most likely be available in 2 years, with primary endpoint of death or unplanned cardiovascular hospitalization. So I think in 750 patients with core lab, CT scan, biomarker, everything you want, and 10 years follow-up. So I think Progress will literally change the way we manage AS patient, whatever the result is. Just a natural history to describe how those patients evolved. Sometimes the answer is not too much into the primary endpoint, but more about how they land in the symptomatic zone, how they progress, how fast they progress.
Right.
So, and the key here is, and this is the next slide, is once you have cardiac damage, do they change? So, and that's why it's so important to prevent this damage, because what we look at in Partner is we took 1,000 patients that had an echo at 1 year, and we saw, all right, all the cardiac damage evolve if you survive. So 15% improved, that's great. 60% remain in the same stage of cardiac damage, no improvement. And 26% got worse. And the people get worse are the one that has severe hypertension that were not treated.
Yeah.
And the one that got surgical AVR because you probably did, create AFib and probably the RV get a hit because of the pump. So I think that showed you that when you miss the boat, you miss the boat.
It's interesting. The damage is done. It's not reversible, really.
I think it also speaks to the importance of addressing people's hypertension. We see them in clinic. We're like, you're doing great. Valve looks gorgeous, but their blood pressure is like 170/80. There's good data for using ARBs and ACEs in these patients to regress some of the LVH. So I think that's
and Joe, to your point, the cancer analogy. So for me, I always said, when you have a cancer, you do a surgery. That's great. You need chemotherapy. And the chemotherapy is this. I think when we I5, we do a TAVR in 20 minutes with 12 minutes in your case. I mean, that's great. But the point is you need chemotherapy. And you need chemotherapy way before you do the TAVR. So that's why you need a center of excellence and valve. Okay, what is the medication we give first to prevent cardiac damage and to reverse remodeling before we start to remove the tumor, right, or the bad valve. So I think for me, this is where I think the medical therapy of valve has to be redefined. And we always scared to give ACE and ARB, and the blood pressure, the spiral down. And well, now the valve is fixed. And now it's time to press on the gas of the medical therapy and have this remodeling fast track,
Totally.
Yeah, that's brilliant. And Philippe, how do you see this changing? Like your practice, you're a super busy TAVR center. 800 TAVRs at Morristown, something like that. Like, I mean, I would.
Philippe does 16 a week. It's nuts.
but for me, I'm limited on. I've got some significant backup on structural cases as is. Like trying to get patients in on time. You think this is something we need to be kind of gearing up for potentially?
Yeah, so I think, it's funny. When I joined Morristown in 2017, I think they were doing 250 TAVR, okay? And the organic growth of Morristown is not only because of me and I brought all those trial and education. It's organically, it's growing. There's more patient. I don't know if AS is contagious, but I can tell you there's a lot of patient. But for sure, it's happening. So whatever we're ready or not, it's happening. So now we're at 750. Now we're on track to do 850. Okay.
Wow.
In 2 years, we're going to do 1,000 at Morristown. And this is the growth. And this is why, because not even talking about early TAVR in progress, just looking at the demography of the field or a community and the under treatment. We still under treat 40% of the patient because, we cannot reach out to them. So just a severe AS with symptoms is going to reach out 1,000 patients for us in 2 years. Well, guess what? I sat with my administration. I showed them the number. I said, guys, I need to be able to do literally 40 TAVR a week. That's mean that I need 8 TAVR a day, 5 days a week. I need 2 room for sure for this, okay? 2 room, 4, okay? And I need 2 new partner, obviously. And this is not even counting mitral tricuspid. This is not counting PFO. So we need 3 room for structural heart if you want to invest in this. And we're going to roll up our sleeve. You can say we don't have enough staff. You can say you don't have enough nurse. Well, guess what? You need to hire them. Otherwise, they're going to go in another center that do maybe 150 or 50. So I think at the end of the day, we start 7 years ago at 250. Now we're 850. We roll up our sleeve and we adapt. But of course, you're going to need to build 2 new cath lab. Of course, you're going to need to have a structural heart program, a structural heart manager. Like you have a cath lab manager, an AP manager. You need a structural heart manager. And you need your full staff that's only going to do that. And that's going to become like PCI. Some week we do 26 TAVR a week here. And it's not to brag about this, but it's happening. Like it's going to happen in your center. You're going to double your number in 3 years. In 2035 is just scary. When you look at the number in 10 years, and I showed that I sat with my administration, so guys, you cannot procrastinate on that because you're going to miss the boat. And this is not even counting severe S no symptom and moderate AS. And all the TAV and TAVs that will come back. So
I saw your talk at TVT, Philippe. It was great. You were saying how 15% of our TAVRs are going to be probably TAV and TAV in 10 years.
Yeah, 1 out of 6, for TAVR will be TAVR and TAVR because, for example, at Morristown we did let's say last year we did 1,000 AVR. Okay, so 250 surgical AVR, 750 TAVR. Well, we do 3 times more, literally, TAVR than SAVR. Well, of course, we're going to have valve and valve that's coming in. By 2028, the TAVR, valve, and valve will be the same as the TAVR, valve, and valve for TAVR and SAVR. And then after that, we're going to totally threefold, and even more. We're going to young people now. We're going to go to bicuspid, this and on that. We're going to go there for sure. Well, yeah, and guess what? Those people in 10, 15 years will come back. So I think we need to get ready. It's if you want to negate reality, it's fine. But I think we have no choice to get ready. So
yeah, no, that's
so I don't know if you want to go to the last slide. I just want to show you maybe the my vision of the future. The last slide when you have everything in perspective. I think the concept is cardiac damage is not. When it's there, it's not improving most of the time, so it's very sobering. And quality of life is completely linked to cardiac damage. So no surprise here. The more damage you have, the less quality of life you have at baseline. And if you go next slide, no surprise here. If you have more cardiac damage at 1 year, you have less chance to be alive, but also less chance to have a quality of life. An improvement in your quality of life. So no surprise. I mean, the sicker you are, the more chance you have to be in heart failure and have symptom of heart failure. So that's why we need to focus on the disease, but on the valve, but also on the damage. So, and if you go to the next slide, you see here that there's a relationship between the change in cardiac damage. Let's say you improve your cardiac damage. This is where give you the most improvement in quality of life. So there's a clear relationship between improvement in cardiac damage and improvement in quality of life. And if you go to the next slide, we're not the only ones showing this. This is Jerome Bax and his group in Rotterdam that's showing moderate AS. If you go to the next slide, there's the same relationship actually with cardiac damage at 5 years in moderate AS. So damage is important in severe AS, but also moderate AS. And so I think for me, this is my vision of the future. And I choose color for the guideline because I believe that's where it should be. We can have the grading of the stenosis like cancer. Is it like a stage 1, 2, 3 grading, the tumor? So mild, moderate, severe. You can keep what you have now with PV velocity, it's fine. And then you have the staging. Do you have, no damage, LV damage, LA damage, PA damage, tricuspid, or an RV, and if you go to the next slide, for me, this is where We already have the indication for AVR when you have severe AS with damage or symptom. Early TAVR will tell us severe AS with no symptom, what we're going to do. And then moderate AS, all the study we do, Progress, TAVR Unload, Expand 2, that all moderate AS with symptom of cardiac damage will tell us, can we go there? And if we go to the next slide, this is where I think there's prevention, or at least secondary prevention, where medical therapy can have a role. So, and I think this slide is what I believe where we should concentrate our effort. I think I've been fortunate to work with you guys, and you were part of Early TAVR and Progress. I mean, to try to define this portion of the field. I think the next 10 years will be all about screening, all about medical therapy, all about bringing those patients and deciphering between the fast progressor, mild. We need to take those patients at mild AS, bring them mild, stratify them, follow them every year, and you get them when they moderate, and then you can help them and maybe change mortality of the disease.
I mean, taking this to a population level, because, you know, anytime you talk about screening, you have to get into population levels with sensitivity and specificity and AUC and all that stuff, Philippe. But I mean, do you think we should be screening for valve disease at a certain age? I mean, because there's so many patients that are just going about their lives with these symptoms and even cardiac damage, and they don't even know it. So how do we address this at a population level? And is there anything being done to do that?
I think that's where I'm getting excited, because, you know, with Early TAVR and Progress, we're just getting started. And we, for the last 15 years, we proved that TAVR is equal to surgery, fine. Now we start the real work, where is, let's tackle the disease. Let's go in severe AS, no symptom. Let's go in moderate AS. Let's go to change the mortality associated with AS. Let's go to prove, and every time I see this statistic, I open all my paper with this line, AS is 3% above 65 or 75%. Guess what? What if it's 6%? I don't know. Did we screen everyone?
That's a good point.
Did you listen to everybody's art? So for me, I think the next 10 years is to try to redefine what is the real prevalence or incidence of aortic stenosis. Use app. There's device on your phone that can detect murmur. There's program at Columbia where they use ECG to extrapolate the presence of structural heart disease. You need to reach out the population. The problem is AS is diagnosed with an echocardiogram. Guess what? It's hard to get an echocardiogram, especially when you live in Canada, especially when you live in demography where it's hard to get an appointment with a cardiologist or an echocardiogram. So for me, you need to democratize the murmur detection. And actually, your company is called Murmur, but I can tell you that
trademark. We got a trademark on that, Philippe.
Yeah, I know, but I'm starting the Murmur Clinic, so maybe I'm gonna trademark the Murmur Clinic. But I think you can have some royalty. But the Murmur Clinic, it's what it's all about.
Yeah, we've talked about that too. Yeah, I mean, it's crazy when you see a guy who walks into your ER symptomatic and he totally unknown. He has a mean gradient of like 65, and he didn't even know he had this health condition. So, yeah, I think how you do that on population level would, you know, I mean, maybe it's just a BNP or something. I don't know.
I mean, the AI stuff, you know, that guy, he gave a keynote lecture at TVT this year, and I was shocked at the sensitivity and specificity of some of the AI EKG detection. So EKG is such an easy test to get, and eventually it'll probably be on your iWatch or whatever, but I think that's going to have huge implications for this field as we go to a population level, you know?
Yeah, I think there's so many ways to go with screening. Obviously, when you enter screening, you're right. It's sometimes it's complicated because I'm not an expert of screening, but for example, colonoscopy, right? You need to show that by screening everyone, you save mortality, right? That's why prostate cancer never get, I think, the screening, because they didn't show that PSA in people save life or save the direction of the therapy, the prognosis. It's complicated, but for me, it's all about management. For example, if you know you have if you know you have a murmur, you have a bicuspid, and you have mild, moderate AS. Of course, you need. If you go to the dentist, you're going to be more careful. Management mean you need to have antibiotic prophylaxis. First of all, you need to know You know that. Otherwise, you have endocarditis. And like you will be a little bit more aware. And I think population education is important. How many times actually I do a TAVR, and then people say, "Oh yeah, I had a murmur all my life," and then I do the TAVR, and then I said, "Yeah, did you get rid of my murmur?" So you know, so I think that the education is missing, and I think this is the future is great. And I said that at TVT or at New York Valve this year is there's never been a better time to be alive with aortic stenosis.
Yeah.
And for patient, because now we're starting to let's try to tackle the disease. And it's not about doing TAVR, it's not about doing surgery. It's about helping patient not to fall into the cliff and to the crack, and managing them. Management mean maybe following them. Antibiotic prophylaxis mean follow up every year. I mean maybe TAVR, SAVR, medical therapy. So I think management of valve disease as a whole is mean much more beyond TAVR and SAVR. It's a patient level, you know.
I love it. Well, Philippe, this was fantastic, man. Thank you so much for your contribution to the field. It's really, it's been huge. I think you've completely shifted the paradigm in the management of valve disease single-handedly, and you're still young. What are you, like 25 or 26? I mean,
what are you gonna do next?
I'm 47, but in my mind, I'm 27. But sometimes, when you're old when you take 2 Tylenol and you feel better.
Dude, when you're doing 40 TAVRs a week, you're gonna get all gray up there. You're gonna need some just for men.
Yeah, I think I need like 3 more partners. But we have such a great team at Morristown. You know, I hate to say that I single end this thing. I mean, Morristown is a great team. We work so well with a surgeon. We have like 5 great surgeons. I have like 3 now amazing partners. We're gonna have a new one coming, Gennaro Justino, and maybe another superstar in the pipeline. But it's a team effort, you know, and it's the process has been fun to work with guys like you. And what I like the most in designing trial and running early TAVR is all the friends we do in the process, and the process is so elevating and humbling at the same time. But you meet passionate people like you, and that are helping so much with the trial, the enrollment, and it's very sharing the passion and then helping patients. And so the last 7 years have been so exciting for me for many reasons, but the next 10 or 15 or 20, who knows, will be much more exciting. I mean, we're just getting started.
Yeah. Love it. Well, we'll leave it on that. Philippe, thank you so much, bud. Really appreciate it.
Thanks for coming.
Great job, and congrats on your channel. It's amazing.
Thanks.